Is everybody seeing the larger screen, not the notes screen? Can somebody?
Yes.
Okay, great. Thank you. You can go ahead and grab.
Okay, sure. So welcome everybody. My name's Carl Wernz. I'm an occupational medicine physician. And I work at a Cabin Creek Health Systems, also do some other consulting around Morgantown. What I wanted to talk about today was the impact of obesity on pulmonary function testing. And just for people who aren't familiar with black lung evaluations, there's a set of testing that you always get. You always get regular pulmonary function testing, FEC, FEV1, and the FEV1 to FEC ratio. A chest x-ray, resting, and hopefully exercise, blood gases, a cardiogram, I get to do a history, and then that's what's required, and you always get that. So I wanted to base my, this report is based primarily on the impact of obesity on core pulmonary function testing, the FEC, FEV1, and the ratio. You are allowed to add other testing. I'm blessed that at Cabin Creek we had lung volumes and diffusing capacities. And so the question the Department of Labor always wants me to answer is, what are the pulmonary diagnoses? And then could the miner perform their last mine employment from a pulmonary perspective exclusively? So, I don't have control. There we go. Okay. So what happens is I see the miner for an evaluation and do testing and then come up with my opinion. The Department of Labor then often will send me another physician's opinions, that has been done usually for the responsible operator, and ask for a supplemental report. And so I got started on this little path when one of the defense physicians attributed a severe restrictive disease to obesity in a coal miner. This is restrictive disease. I don't have the case. I should include the case here, but the person's FVC was around 50% predicted, and their BMI was 32. And so one of the things that happens all the time when we do these sorts of evaluations is that I have to correct for various anatomic abnormalities. This is just a brief example of some of the other ones that I've already kind of worked out. So lobectomies can obviously affect the FVC. Sternotomy has impact shortly after surgery, but not much a year later. And then paralyzed diaphragms. There's some examples of anatomic abnormalities that I figured out how to correct for, or found literature that helps me correct for those. So the question I had was, how do I correct for the impact of obesity on pulmonary function tests? Back in medical school, I had learned about, that there's this Pickwickian syndrome thing, and I thought that was important, but I was just curious, how big is this impact? And also, at what level of obesity is this seen? I realized that you become obese with a BMI of 30.1, but are there really lung function impacts at that level? So this took me on into this rabbit hole, which took me back through. I went into the really early literature. Now this is from 1810, and this is from. This is actually I found this actual article because it's been reproduced. So that a country tradesman aged about 30, of short stature and naturally fresh, sanguine complexion, and very fat, applied to me for assistance. He complained of a perpetual drowsiness and inactivity. His countenance was almost livid, which I had to look up, which means dark bluish gray, and to a degree of somnolence attended him that he could scarce keep awake whilst he described his situation. In other aspects, he was well. That's back in 1810. In 1956 was when the famous paper initially coining the phrase Pickwickian syndrome was published by Sidney Burwell. Now he described it as occurring in people who are obese, but also in other conditions that will cause increased abdominal girth, specifically pregnancy and ascites. You can see this as well. Clinical features were the marked obesity, somnolence, twitching, cyanosis, periodic respirations, polycythemia, which he thought was secondary, right ventricular hypertrophy, and right ventricular failure. So what if you kind of think about what we know about this now, we may have a different diagnosis of this person today. So just so we've covered the literature part of this, this reference came out of the posthumous papers of the Pickwick Club, which was a Charles Dickens novel. So I call this is the first discussion in the literature of this condition. This is truly literature rather than medical literature. And it was this Joe who was an assistant or a helper, and he was introduced as being so somnolent that he would fall asleep even standing up while knocking on a door. In various places in the book, Dickens called him young dropsy and young opium eater, although he did not have dropsy or eat opium. There was a case that was included in this initial paper. The gentleman in the case was 5'5" and 263 pounds. He gained weight from 200 pounds over about a year. And the original description was that he was florid, had a cyanosis of the face and nail beds, but no clubbing the fingers, extremely somnolent, several times fell asleep in the middle of a conversation. His eyes would close and he would snore. When roused, however, his mind was clear and his intelligence obvious. So they hospitalized him and starved him on an 800-calorie diet, and he rapidly lost weight of about 20 kilograms. We're fortunate that they collected data on respiratory function and ABGs. This is actually in the paper from 1956. So you can see here the one to pay attention to is on the left, the middle one. That's vital capacity, which is essentially equivalent to forced vital capacity, just done in someplace not the United States. Those two numbers should be about the same. So you can see that when he was initially hospitalized, his vital capacity was maybe 1.5 liters. And with weight loss, and if you look, you have to kind of look at the bottom thing, he lost about 20 kilograms approximately, and had his vital capacity increase from, let's say, 1.5 liters all the way up to maybe 3.5 liters with 20 kilos of weight loss. And just for reference for people who pay attention to these things, his BMI went only from 43.8 down to 37.8. So yes, it's significant weight loss, but it was not like he went from, I don't know, a BMI of 50 to a BMI of 22 over the course of that hospitalization. The other thing you need to notice is if you look at the right-hand column, you'll see that the arterial oxygen concentration increased, I think, although I don't 100% know that. I believe that that's the PaO2. So it went from an PaO2 of 80 during the day to a normal 95-ish. And the PCO2 went from 74 down to normal of around 40 or 45. So quite a bit of change in his both the vital capacity as well as the blood gas with weight loss. There's a tiny little problem with this study, and that was that the N's won. Now, unfortunately, this has become, I don't know whether I want to call it legend or history or something, but in medical school, they talk about Pickwickian syndrome and how these people who are obese can't breathe normally. And that, I presume that that's still taught as you pass through medical school. And that's what most information that most people have about the impacts of obesity on breathing. What this guy really probably had, now that we know a little bit more, is what we would today call obesity hypoventilation syndrome, which is obesity, daytime hypoventilation, and sleep disordered breathing without another cause. And if you kind of look at the official definition there, he had hypercapnia, he had hypoxia during the day, he was obese, he had sleep disorder. Well, we presume he had sleep disordered breathing because he kept falling asleep during the daytime, and there was no other cause found. So I really think that what we learned as Pickwickian syndrome in medical school is really just really bad sleep apnea. It's so profound that with such a profound respiratory alkalosis that the person cannot correct during the day, and so they still have daytime abnormalities. I really think I think this is what Pickwickian syndrome really is. So I went still looking at trying to figure out how much impact there would be on normal pulmonary function testing from obesity. I found several papers that were that address this topic, and what I will say is that the results are somewhat variable, but never very severe. So this is one article by Sood, who's looked at this. This is from 2009. Vital capacity he found to be normal or slightly decreased. FEV1 was normal or decreased, and then the ratio could be anything, up, down, or the same. A different article by Sood, he was looking at before and after bariatric surgery. They didn't do, in this study, they didn't report their vital capacity or FEV1, but the two that they did report that were interesting was the residual volume, which increased quite a bit. You can see there from maybe 95% predicted to like 120% predicted, and then the total lung capacity that also went up. They've done studies. This is an interesting study from China, and they looked at just in Chinese college students at what they looked at what are like normal spirometry values in this population. And one of the ways that they sliced and diced their population was by BMI. Now it's interesting to note that underweight's less than a BMI of less than 20, overweight or obese, which is a very, very small group of their population, was a BMI of greater than 28, and they only had 33 students out of about 2,500 that were in their 2,600 that were in their study. What they noticed, it was kind of interesting to me, was vital capacity increases on average with increased weight, and this is seen in some other studies as well. When they were looking at creating what we all now know and love as the NHANES spirometry normal values, Hankinson looked at the impact of obesity in the NHANES population. He looked at height, weight, BMI, and other things, and he concluded that there was really no benefit to adding weight. That height and weight both had the same impact on the final predicted values, so there was no benefit in adding weight to that equation. A study was done back in 2008 where they looked at pre-op bariatric patients and then followed them over time. This is just the pre-op one. They found that most of the people were in the normal range. There was maybe some impact on the ratio, but they couldn't figure that out because nobody else had seen that particular thing. But they found no relationship between body size and spirometry results in their population of 136 pre-op bariatric patients with a mean BMI of 57. So this is a morbidly obese population that they were looking at. This table comes from a study that is actually hard to find because they didn't. It's just weirdly indexed in PubMed. But what I wanted you to look at, so this is a study where they looked at this is a study of a couple hundred obese subjects who passed through the pulmonary function lab, and they only looked at the ones that had normal pulmonary function tests. So if your FVC or FEV1 or ratio were below the lower limit of normal, you're not included in this population. So that's your starting point. So because these are people that went to the pulmonary function lab, I'm sure some of them were pre-op or had other reasons for getting, were otherwise normal, but some of these people could have been symptomatic. So just kind of keep that in mind as you think about this. But they were looking at a relatively large group of people who with various BMIs, which are across the top. So BMI of 20 to 25, which they kind of considered the baseline, and then out through a BMI of greater than 40. The first thing I want you to notice off this table is that the ratio and DLCO were not impacted even in the most profoundly obese group of people. So the ratio is safe through all this through all these testing. The vital capacity does have some impact. You can see that these are the means for the group. So it went from a mean of about 97.8% predicted, 97.6% predicted for people who I think they would call normal in the 20 to 25 BMI range, and did decrease down to about 87% predicted when the people's BMI was over 40. The functional reserve capacity had the FRC and the expiratory residual reserve volume had the biggest impacts. And these are real. These are seen in almost every study. But interestingly, they don't really, it's not, you may notice that the impacts on FRC and ERV are far greater than the impacts on vital capacity or FVC that you see up at the top of the screen. And just right below the red box, you'll notice that the TLC line does show some decrement as you go across the increased BMI ranges. Residual volume goes down a little bit, but not a lot. So there've been this is a summary study that was done in 2014, and they looked at a variety of factors across a whole bunch of studies. It's kind of a meta-analysis, sort of. I think they looked at the outcome of the study, not necessarily they didn't, I think, combine the data. So things to notice off of here was in the vital capacity column. So just to explain how this works, in this study, if there's a pound sign, or what we now call a hashtag, that means that they studied that thing in that study. They reported results. If there's a star, that means that the variable was reduced in association with obesity. So, for example, in this, in the column for vital capacity, you'll notice that four people have hashtags, 4 studies, and that means that 4 of them actually looked at vital capacity. Only 2 of them have stars, so only 2 of the 4 studies found a decrease in vital capacity, or about half. Oops. Sorry, we're going to get 2 at the same time here. Pay attention to the green column first. For forced vital capacity, the ones that studied that, they noticed about 4 out of 7 studies found a decrease in forced vital capacity. It's key to notice that 2 of them disagreed with each other between vital capacity and forced vital capacity. And so you'll notice that where there's a star in the one column and no star in the other column. So basically, for vital capacity or forced vital capacity, it's a toss-up whether I don't think there's any significant impact, because the studies with, all the different studies playing or being evaluated, there's, at the end of the day, it's about 50-50 whether it causes any impact or not. I don't think there, and my summary of that is I don't think there's a significant impact on forced vital capacity from obesity. The other thing to look at is FEV1. Sort of similar results. All 9 of the studies looked at FEV1. 6 of them found that there was a decrease, and any decrease, so if it was 99% predicted, that's considered a decrease, just so you know that. So that there may or may not be, again, we're back to a very mixed bag of when you look at various studies of whether the FEV1 is impacted. So some conclusions. Pickwickian syndrome really is a real thing, but it's really profound sleep apnea, and which we now have a good mechanism for treating, with CPAP and other effective treatments for sleep apnea. Obesity does not, on the basis of my review of the literature, in and of itself cause significant pulmonary function test changes for FVC, FEV1, and FEV1 to FVC ratio. You may see subtle changes in, but I'm not convinced that those really exist. I mean, these are like taking us from 100% predicted to 95% predicted, not taking you outside the normal range. Obesity clearly does impact lung volumes, especially the ERV, FRC, and TLC. There really is, I think, some impact there. So keep in mind that if you've attributed findings to obesity with pulmonary function abnormalities, you may want to reassess that in anybody who's not profoundly obese. I don't think there's any impact from anything but upstream obesity on regular pulmonary function testing. Again, not lung volumes. Some of the studies found that weight loss can really improve the pulmonary function tests, maybe even into a high normal. So some of the studies, if you looked at them when you went from obese to through the whatever the weight loss process was, the post testing found super normal findings. Maybe 110% predicted kind of was where those groups went. And keep in mind that obese patients can have lung disease too. Are there any questions or any discussion?
There was a question on the chat while you were presenting about sleep apnea and narcolepsy. Now, Dr. Sila kind of took that question for you, but I didn't know if there wanted to be any further discussion on that. Most everyone is muted, by the way, so please check the bottom left-hand side of your screen to unmute yourself.
I think that's Dr. Stansberry that may have also answered. And if that's the case, I would let him take this as he's the sleep medicine trained physician. If he's there, I can't see.
Hold on.
Yeah, and I agree. In 1810, all this, or even 1953, we didn't have sleep apnea was understood, and it clearly there was no treatment available. So actually, forced weight loss may have actually been the most effective treatment available in 1953. I mean, maybe.
Okay, there I'm on now.
Yeah, or a tracheostomy.
We were having some issues logging on this morning from Fairmont.
Okay.
Yeah. So, I guess kind of what I wrote, sleep apnea is really a disorder mostly driven by anatomic abnormalities in the upper airway, whether it's related to obesity or, just congenital. There's a strong family component to obstructive sleep apnea. And, it's really just factors that portend airway collapse when you're asleep. The primary treatment, CPAP, is really just acting as a pneumatic splint to keep the airway open. Where narcolepsy is actually a neurologic disorder where there's a absence of a neuropeptide in the brain called orexin or hypocretin. That's really important in sleep regulation and probably most importantly in regulating REM sleep. So that's why in narcolepsy, it's really a disease of abnormal REM sleep intrusion. That's why, when you're in REM sleep, you're paralyzed. So that's why you get cataplexy. When you're in REM sleep, that's your dream sleep. So that's why you can have hypnagogic and hypnopompic hallucinations. So they're, very different disorders.
Great.
Hi, this is Sam Giordano. It was a great presentation, by the way. And I recall back in the 60s, actually, I was working at Cook County Hospital, and we had lots of patients presenting with what we referred to as Pickwickian. And of course, this was well before we understood sleep apnea. And certainly a large percentage of those patients were sleep apneic, but we had some that were morbidly obese that were truly old Joe in Pickwick papers. But I also wanted to ask, was there any in the studies? Was there any notation of the amount of physical activity or exercise of any of the participants of the study?
No, these were mostly based on the most data I ever saw was you would get data on gender and sometimes age groups and stuff like that, but they never talked about activity.
There are a couple of papers out there with obesity and spirometry looking at position but not activity. And just as you would expect, position exacerbates the findings that were just discussed. Being flat versus being upright, sitting versus standing. So that data is out there, but there's not a lot of data about, or I don't know of any about activity per se in spirometry.
Yeah, there was a study that I ignored that compared supine spirometry with vertical spirometry, where there is a much greater effect, but because we don't I'm not aware of anybody that does supine spirometry. I don't know I don't know in the US why you would do that, or quite honestly, unless you're, I don't know, in the space station or something. So I didn't really pay much attention to that study, but there is a bigger effect on, FVC does have an effect with obesity if you're supine. But again, we don't do that clinically, so I wasn't worried about that.
So
Sometimes we will.
Clinically and fairly commonly is where you suspect bilateral or unilateral diaphragmatic weakness or paralysis, because that's where you do find spirometric changes that are reasonably helpful in making diagnosis. So it's done in a very specialty setting, in a specialty area. It's probably not something that you're going to do on a routine basis, but it's done enough that this was a paper to demonstrate. I think the one you're talking about was to demonstrate obese people had some of those same changes that those who have paralyzed or unilateral or bilateral diaphragms have.
Okay.
Yeah, we occasionally do order upright and supine spirometry for that reason.
Okay. As an occupational medicine physician, that was above my pay grade, but I'm glad to know that it is actually used.
I'd also say that the whole presentation goes, I think, back to the whole discussion it's been at national levels for a long time, is that it's hard to figure out what spirometry and lung volumes mean half the time, because there's a lot of variables that don't seem to make sense or have any impact at all. And so I've always been taught that ERV is an indicator of, a low ERV is an indicator that your restriction may be due to obesity. And it's pseudo-diagnostic, but not particularly clinically useful other than that.
That was actually a board review question. Yep. For pulmonary. Yep.
I got that one.
Yeah, me too.
Not so much the ultrasound.
Any other comments from the group? Dr. Doyle, thanks for joining. See you there.
My comment is, Dr. Wertz, thank you so much. That was a really fantastic thing that we're covering of an objection that we frequently see on DOL exams. And so I feel like I have a much better, and Dr. Allen's seconded my motion. Yeah. So I feel like I have a much better understanding of the issues involved. So thank you.
You're quite welcome. Thank you, Dr. Allen, for the one paper that I hadn't found. That was useful. But this is like, again, I guess the take home message is you shouldn't see weird. It's normal. The core pulmonary function test really shouldn't change much with obesity, and it's anybody that's attributing significant changes to that probably is it's not well founded in the literature. I'll just say it that way.
Okay. All right, thank you, Dr. Wertz. Is there any other comments or questions can be related to the presentation or anything else? We still have a couple of minutes. No? Yep.
Dr. Sela is reminding me to talk about the ILD clinic we've initiated at WVU, just so people know. Thank you, Allison. It's Dr. Zulfikar and Dr. Sangani. It's an interstitial lung disease clinic. It's the first Friday of every month. Their clinic's already packed full, so I think we're probably going to be expanding that pretty soon. But just as a support and reference, if you guys need any help with your ILD patients, that's available now.
Great. Awesome. Okay.
So, and our next meeting, I don't know if we've changed this yet, but it's during the ATS. So I think there'll be a fair number of people out at the American Thoracic Society meeting. I don't know if we want to look at another date or how you want to.
Okay, I'll check on
Okay,
that.
yeah, we'll follow up. Okay. All right, everyone. Thank you so much for hopping on and taking the time, and we will we'll reach out and let you know about the next session.
Hey, Jay, before you end, Tim Ritz is requesting in the chat box that we get the contact information for the clinic. I guess the ILD clinic.
The ILD clinic. Yeah, I can work on that for you guys. Can I? Yeah, I'll work on that and see if I can get it sent out to everyone.
Okay, sorry to interrupt, Jay.
Yep.
That's okay. You can send it to us, Dr. Stansbury, and we can send it out to the group.
Okay.
Yeah. All righty. All right. Well, until next time, we'll see everyone later.
All right. Take care. Great talk.
Thank you.
Everybody have a great day.
All right.
Thank you.
Thank you again.